So we are Team Jams, and we are doing our group project presentation on nerve stimulators. There are a lot of different kinds of nerve stimulators, so we decided to narrow down to spinal cord stimulators and pacemakers. Moving into the science and technology, both of these devices have very similar methods of action. The electrical impulses are sent from the generator to the electrodes, depending on what the needs of the patient are. Spinal cord stimulators inhibit pain signals from reaching the brain and are activated by a remote control that the patient has. Pacemakers stimulate specific areas of the heart preset by the provider to detect bradycardia. Components of nerve stimulators. There are two main parts: the generator, which is the battery, memory, and housing for electrical potential, leads or electrodes, which are specifically placed depending on the needs of the patient. Spinal cord stimulators. The generator is placed in the lower lumbar region or the abdominal area. Electrodes are placed in the epidural space of the spinal column. The pacemaker generator is placed below the skin of the collarbone on the left-hand side. Electrodes are placed in either the right ventricle, right atrium and ventricle, or both ventricles, depending on the needs of the patient.
The history of the spinal cord stimulator device begins on June 3, 1919, with the electric massage machine. It was the first electrical stimulator, and it was advertised as the Electrete. It was marketed to alleviate not only pain, but a long list of just about every physical problem imaginable. It weighed nearly 1.5 pounds and was shaped like a long flashlight, around 28 centimeters in length, and contained 2 D-cell batteries. With advancements of pain perception, the Electrete was reinvented and later called TENS, transcutaneous electric nerve stimulation, based on the idea that the sense of touch transmitted by large neural fibers could also be transmitted through the application of gentle electrical stimulation. The development of the modern TENS device is credited to Dr. Norman Shealy. He devoted himself to research neuromodulation, including TENS, the spinal cord stimulator, and the radio frequency ablation. In 1967, he had the idea of stimulating the large fibers in the dorsal column of the spinal cord and tried the spinal cord stimulator implantation, which was successful. The first spinal cord stimulator was commercially available in 1968. The early model spinal cord stimulator required an external power supply connected to the electrode. However, battery technology advanced to the point where a fully implantable spinal cord stimulator was available by 1981. In 1932, an American physiologist was interested in reviving the heart via intracardial injections, where stimulant drugs were being injected into the heart through a needle. However, he soon realized that it was not the drug that was restarting the heart, it was the needle as it punctured the cardiac wall. From there, he developed the artificial pacemaker, a device that produced electricity through a needle punctured into the heart. It was operated by a hand crank and spring motor, which turned a magnet, known as the DC current generator, to supply the electricity. The device was used in the New York area, however, it was not accepted by the medical community. Eventually, his work was derailed by technical problems and the attitude of the times. In the 1950s, the Electrodyne PM65 pacemaker, an external tabletop pacemaker successfully designed to treat heart block, was developed. It delivered periodic electrical impulses and volts to a pair of metal electrodes strapped to the patient's chest directly over the heart. Unfortunately, the electrodes irritated the patient's skin, and the patients found repeated electric shocks painful. Also in the 1950s, the mains-powered portable pacemaker was available. However, they were very large, bulky boxes filled with vacuum tubes and had to be wheeled around on carts plugged into main outlets to obtain their alternating current power. In 1957, after a tragic death of a baby due to limited technology, an electrical engineer developed the first working battery-operated pacemaker. It was apparent that for those who need long-term pacing, a totally implantable device would need to be designed to decrease infection. October of 1958, the first pacemaker implantation was performed. The entire unit was entirely handmade and consisted of nickel-cadmium batteries, the electronic circuit, and the coil recharging antenna. These were encapsulated in a new epoxy resin which had excellent biocompatibility. The first pacemaker implanted functioned only a few hours, but the second one implanted in the same patient had better longevity. However, it only lasted about a week, and it was suggested that there was probable lead fracture rather than pulse generator malfunction. In June of 1960, the first successful pacemaker was implanted, and it helped a patient who had a complete heart block. Pacemaker and lead technology continued to develop rapidly to make these devices reliable, automatic, and flexible in the therapy that they provide. In the 1970s, the lithium-ion battery was developed to replace the mercury oxide zinc battery that had been used until then, resulting in an increased pacemaker longevity. Titanium casing was also developed, which replaced the epoxy resin in the silicone rubber that previously encased the internal components of the pacemaker. In the 1990s, the microprocessor-driven pacemakers appeared. They became very complex devices capable of detecting and storing events utilizing several algorithms. In the 2000s, the biventricular pacing for heart failure was introduced, and an additional special designed lead was also introduced, and this improved the symptoms and survival.
So for uses of a pacemaker, it helps regulate the heartbeat, helps with arrhythmias, weak heart muscle, tachybrady syndrome, heart block, and for the spinal cord stimulator, it relieves chronic pain. Pacemakers help a patient be more active with less worries on their strain of their heart. They help patients live longer by helping with body's homeostasis along with keeping the patients from too many medical visits. For the spinal cord stimulators, they help the patient be more active and improve their quality of life and sleep. Even though some other pain treatments and pain medicines may still have to be used with it, it is still less and far more effective.
So I'm going to talk about limitations. One of the limitations in nerve stimulators is fluctuations in stimulation. Unwanted changes in stimulation may include a jolting or shocking feeling. If the device at this point should be turned off and the doctor contacted if this occurs. If the therapeutic increases so much that it just shocks you, it might be malfunctioning. Another limitation is pain is just not resolved. Spinal cord stimulation interferes with pain signals into the brain but does not treat the underlying condition. People using this therapy need to continue working with others on their healthcare team. An example of this is physical therapy. Another example of limitations is electromagnetic interference. Strong interference such as from a defibrillator or MRI, if it's a spinal cord stimulation device, it is not MRI safe and can damage the generator, leading to severe burns, other serious injury, or death. Skin irritation may develop near the generator relating to charging. In pacemakers, an exposure to a static magnetic field can cause the switch in an asynchronous pacing mode, or it just knocks it out of sync. People with pacemakers are known to be advised to stay away from magnets. Another limitation is reaction to pressure. Those using spinal cord stimulation should not take part in activities that add pressure to the body. Scuba diving more than 10 meters below the surface should be avoided. So some potential safety concerns for nerve stimulators, especially for spinal cord stimulation, is infection. And it says one study found that more than 4% of SCS patients develop an infection. For patients with diabetes, the infection rate went up to 9%. Another potential safety concern is cerebral spinal fluid leaks due to close proximity of the spinal cord during the implantation of the SCS device. It is possible for the cord's outer layer to become punctured and develop a cerebral spinal fluid leak. A common symptom of CSF leaks is a headache that gets worse with certain positions, such as leaning forward. A CSF leak typically goes away within a few days with rest and drinking plenty of water, but in some cases requires surgery to treat. And lastly, paralysis. While rare, a more significant injury to the spinal cord can lead to paralysis of one or more limbs, or the loss of bodily function, such as bladder or bowel control. And another potential safety concern for not just spinal cord stimulation, but pacemakers. For pacemakers, blood clots, they can develop in one of the veins in the arm or on the side of the body where the pacemaker was fitted. This may cause some swelling in the affected arm, but it usually settles in a few days and is rarely a serious problem. In some cases,
Currently, some medical supply companies such as Medtronic are developing a recharge-free spinal cord stimulator device that are lasting up to 7.5 years, which is twice as long as other comparable devices. SureScan MRI technology is also being developed as a means for patients to safely get an MRI. Pacemakers are always evolving. The future hopes to bring cardiac resynchronization therapy, especially for those who have heart failure desynchronization, batteryless and fewer leads as a faster form of recovery.